Assalamu alaikum, the Room Clinical Consultation Day. First scenario, Mr. James Adam, 75 years old male, referred from the GP with abnormal movements. This problem has been there for 25 years. Recently, it became worse. The vitals are within normal. His blood pressure 150 over 88. Ready, Dr. Henry?
Yes.
Here you go.
Hello, I'm Dr.
Hello.
Henry. I'm one of the doctors here. I received a letter from your GP concerning your condition. Can I please start by confirming your age and name?
Yeah, I'm James, 75. As you are entering the cubicle, the patient is sitting and his head is shaking, his hands are shaking.
Okay. Mr. James, could you mind telling me a little bit of your condition?
Well, the shakiness has become worse in the last 4 to 6 weeks. I've been to my GP, so he asked me to, he referred me to you.
Okay. So sorry about your condition, but not to worry. We'll see how we can do to assist you. How about that? All right.
Yeah.
Concerning your shaking, which of them started first? Is it your head or your hand or which part of your body is shaking?
Well, my head, my hand, um, it's not particularly my hand, but also my arm. Um, and this has been the case for 25 years. It wasn't that much evident, to
Okay,
be honest.
okay, okay. Okay, so it has been getting worse recently, right?
Yeah, in the last 4 to 6 weeks.
Okay. I also noticed that your blood pressure is also elevated. Are you
Mhm.
also having high blood pressure?
Yeah, I'm having high blood pressure. I am on medications for that.
Okay, okay. We'll discuss that. Concerning your, do you notice anything that make the shaking needs to be worse or probably made it to be increased?
What make it worse and what make it increase?
Yes.
It's now been worse, but in
O-
in the past, then I think it was the sleeping make it better.
Okay.
But
Okay.
now it's all the time.
Okay. So sorry about that. All
Yeah.
right. Do you notice that probably when you take, probably when you take some medication, have you been on any medication on this particular condition?
Oh no, no, no,
No medication at all. All
no.
right. Okay. Do you have any?
It wasn't bothering, so I didn't go or to seek any
Okay.
medications for that.
All right. Any issue of headache, neck pain, or neck stiffness?
No.
Any issue of, one weakness of one part of your body, facial deviation or loss of speech?
No.
Any issue of feeling dizzy or loss of consciousness?
I have been dizzy and had falls, yes.
Okay, so sorry about that. For how many times have you had fallen? Have you
It
sustained
was
any
in the
injury following
last
fall?
years. It was in the last year, and I think it was 3 times in the last year.
Okay, so sorry about that. Have you developed any injury following the falls?
Um, Not very strong injury. It was uh uh I fell uh on my head, but there was no bleeding or anything.
Okay, all right. Um, any issue of blowing of vision, throwing up, or feeling sick?
No, not at that time, no.
Okay. Any issue of forgetfulness, misplacing of objects, or reduced attention?
No,
Okay. Any issue of feeling numb or pins and needle sensation or inability of to move your body?
No, now controlling my body is difficult, but
Okay. Okay. And if I may ask, do you have any similar outside the high blood pressure that you have been having? Do you have any other condition you have been managing before now?
no.
Okay. Any family history of similar condition?
From my father's side, no. My mother was adopted, so she doesn't know.
So sorry about that. Okay. Have you had any surgery done before?
Um, no.
Any recent hospitalization?
No.
Out of recent procedure done?
No.
Okay. Any blood transfusion?
No.
Okay. Do you have any which medication are you currently taking outside your which for the high blood pressure?
It is amlodipine and ramipril.
Amlodipine and Ramipril. Okay. For how long now?
Hmm?
For how long
For
have you been taking this drug?
for the last 8 months.
Okay. Did you just increase the dosage of any of them?
No, no, no.
Okay. And what's your have you been regular with this medication?
Have I been?
Regular, as in regular in this medication?
Yeah, 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 yeah.
Oh, okay. All right. Sorry, I want to ask more, kind of yes and no question if you don't mind.
Mhm.
All right.
Please.
Any problem with your vision?
Now I can nothing I can notice now.
Okay. Do you drive?
Yes.
And no, any difficulty driving?
Um, Difficulty to control the signals behind the wheel.
Okay.
That's
All
it.
right.
Yeah.
All right. So at this point in time, because of your difficulty, I would advise you stop driving until we look for the solution to your problem. How about that?
Yeah, yeah, that's fine.
Okay. Do you have any problem with hearing or taste?
With urine?
Hearing, as in to hear, as in any hearing impairment. Did you hear very well? As I'm talking to you, are you hearing me very well?
Oh, hearing. For
Yeah.
hearing, I'm sorry. Yeah, yeah, I'm hearing very well. Yeah.
Okay. Any difficulty in swallowing or loose
Mm.
stool?
No,
Any constipation?
no,
Tummy swelling?
no,
Any shortness of breath or cough?
no.
Any pacing or raising of the heart?
Any?
Pacing or racing of your heartbeat?
Um, no.
Okay. Do you have any problem with your water work?
No, 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 no,
Okay. Any joint pain or back pain?
no.
Okay. What kind of job do you do?
I used to be uh, uh a teacher.
Okay. So, what's the impact of this condition to your job and to your daily activity?
I'm currently don't work now. I'm retired, but it is now impossible to do the
Oh,
simple things to hold a cup of tea. I don't drink now any hot drinks
oh,
for the last months or 2 months because it spells everywhere.
mhm. This can be really difficult for you. Will you
Mhm.
will you mind if we probably serve as an assistance to you by sending you some help from our social service for domestic aid? How about that?
Yeah, that's fine. I
All right.
appreciate the help, yeah.
Thank you very much. Okay. All right. Do you smoke or take alcohol?
Don't smoke. Um, Drink alcohol on a
Mm,
weekends, just
okay. All
two
right. But
glasses of beer.
two
No.
glasses. Okay. All right. Do you have any idea what might be the problem with you? What might be the condition you're having?
Well, I was wondering, is it is it Parkinson, to be honest?
Okay. Your your idea is valid, but not to worry. We'll get a lasting solution diagnosis for you. Do you mind if I examine you?
Please.
All right. First of all, I want to look at your hands and see if it is spontaneously shaking or if it has rest. If is it Is
At
is that
rest, the patient torso, head, and that left arm is shaking.
okay? At rest. Okay, the left hand and the head is shaking. All right.
Mhm.
If I may ask, sorry, do you have any tummy swelling or yellowness of the eyes?
No, no,
Okay. All right. I know history of trauma to the head or road traffic accident.
no,
Okay. It's not involved in any like boxing or multiple
no.
trauma. Okay. All right. And then I want to look at and then ask him to walk and check at the gate. How is the gate like? Is it a fascinating gate or is
The
it
gait is normal.
gate is normal? Okay. Patient goes back. Okay. Then I
Anything
look at
you would like to examine whilst the patient is standing?
yes, I want to look at the if it's having the posterior, the what do you call it? Examine the rhomboid text. How is rhomboid test?
Romberg test. Romberg test is negative.
Negative. Okay, then I do try and look at the gate. The gate is normal, right? No,
Yeah.
what's the gate like? Any attack the
N-
gate?
No.
Okay. Then I probably take permission. I will want to do some okay, I'll leave it, it's not necessary. Then I'll ask him to sit down, put pillow on his hands and check for look at the
Anything else you would like to examine whilst the patient is standing?
mm, I want to
It's
look at
fine.
the tremor, wind beating tremor, any wind beating tremor, ask him to beat the wind and see if there's any tremor while beating the wind.
Tremor off?
Yeah, wind beating, ask him to flap to see if there's any
Oh,
see the okay, no tremor. Okay.
no. Just to, when his hand is outstretched.
Yeah,
Okay, so you are now screening of the patient function. So his hand is outstretched, his eyes open. There is shaking of his hand. Okay.
oh, okay. All right, then
Next.
okay, then I asked him to stretch his hands and see if it worsen when he moves his hands to see if it's an intention tremor.
No, so his what I've described that his hand is outstretched.
Okay.
Okay. Did you mean anything
Yeah, asking
else? I didn't hear it appropriately. I'm sorry.
is the tremor worsen when the hand is outstretched?
Yes.
Tremor is worsening when the hand is outstretched. Okay. Then furthermore, I want to look at the check for tap the head check for glabellar test, tap the forehead and see if it's continuously blink his eyes. Glabellar test, is it positive?
Um, Ignore this test.
Okay, then I want to do the check for the eye ophthalmoplegia. Can you please look at my head and follow my hands and
Okay.
check for the ophthalmoplegia? Any
No
nystagmus?
ophthalmoplegia. No
What of
nystagmus.
nystagmus? Okay. Then
Anything else you would like to see in the patient eye?
then if there's any uh, uh, any ptosis, any
No
cataract,
ptosis.
any
No
cataract,
cataract.
then since it's hypertensive, I want to ask if there's any problem, check for fundoscopy and check for
No
retinopathy.
need to do fundoscopy.
Okay,
No
then
need
I
to do
look at the
fundoscopy.
okay, then I look ask him to open his
2 minutes
uh,
left.
okay, then I ask him to write down and check for the micrographia and see if there's any micrographia. Any micrographia?
No micrographia.
All right. Then I check the tone and the check the
Tone
tone.
is tone is normal.
Okay. Then power is normal.
Power is normal.
Okay. Then do you have any concern if it starts?
Yeah, doctor, is it Parkinson? This my
Um,
concern remains.
your concern is valid. Actually, what I think you are having is a condition called essential tremor. Is a condition that sometimes can be found in the family.
Hmm.
However, we may need to do some other tests to rule out other things that I'm also thinking of, such as blood tests, your scan of the head, and then we it is something that we can manage. And if we give you some medication that might control it, and then we may
Hmm.
need to involve other doctors that will probably help you
Hmm.
out, your other doctor that will help in assisting you. How about that? You have
Yeah.
any other
Yeah.
concern?
Would the medication help?
Yes, the medication will help, but like I said, if it doesn't help, there are still some other things we might do. Things like what they call some device might put in your brain known as deep brain stimulation. But when we get to, we may need to discuss that subsequently in our next meeting. But not to worry. Any other concern?
Shall I continue driving?
At this point in time, I'm afraid so. You may need to stop driving now. And
But would we revise that with the medication if everything is controlled? I'm banned from driving?
as it is now, until for now, I'm afraid so. You are.
Okay. Time's up.
All right.
Yeah,
Okay.
examiner question, Dr. Amar, you can start the same questions.
So, doctor, can you present this case for me?
Okay.
And what's your finding?
I've seen Mr. James Adams, a 75 years old non-hypertensive patient who presented on account of worsening of the shakiness of the hands and also the heads and some other parts of the body. However, there's no a family history of similar condition could not be ascertained, as he has no history of that. Condition tends to worsen when he's involved, when the hands are stretched, and then relieved during sleep. He has he's on amipuri and amlodipine for his hypertension and regular medication. On examination, the BP is said to be elevated. There's intention tremor with also titubation of the head, and I have no evidence of fascinating gait, bradykinesia, or reduced tone or increased tone. And
But have you tested for bradykinesia, Dr. Henry?
when I ask him to walk, there's no reduced movement in terms of walking, but there's no bradykinesia.
Have you screened the function? Have you did a complete screen of function in
No,
your start?
I didn't do the complete screen of function.
Okay.
Yeah, I didn't. To be candid, I did not.
Okay.
I should have done it, but because of time, I did not do it.
No problem. So please continue.
So in line with my history and examination, I'm thinking that my patient, that Mr. James, could be having essential tremor, as my diagnosis or my differential diagnosis could also be Parkinson disease. We could also, because of the high blood pressure, to also consider vascular dementia. However, there's no history of dementia. The patient
So
doesn't
why
have
you've
it
included it in your differential?
because of the animal movement and the high blood pressure, basically. And I'm also considering it could still be that he has other
Any other possible differential, Dr. Henry?
outside
This gentleman does have this problem for 25 years, and it's now has gone worse. Do you think it was Parkinson's 25 years ago?
I think it could be essential trauma, like I said, but other than essential trauma, I'm also considering that he may be having things like Wilson disease, but however, there's no
Could
family
it
history.
could it be essential tremor in his 50 years old when he
Yes, it could
was
be
50
essential
years
trauma.
old?
Yeah,
Any
it
other
could be,
possible
yes.
differential
Like I said,
other than this?
other than it could be Wilson disease. But however, it could be Wilson, but there's no evidence of no abnormal liver, any condition suggesting of liver pathology here. And
So have you checked the patient eye, Dr. Emeka?
yes, I didn't send any catheter, but I would have loved to, do a what do you call this test, examine using a slit lamp to check for
Okay.
evidence of, but I could not see anything visible when I examined the eye.
Okay. Okay. Any other possible differential?
Outside Wilson, outside Parkinson, outside the essential tremor, I will be considering what do you call it? It could be no, not drug induced. It could be that he's having because of his age. It could be PSP. However, there's
This
no
is in Parkinson's plus, no, outside of Parkinsonism.
kind of Parkinsonism outside of Wilson, outside of it could be tremor. Okay. I could say drug induced, but there's drug induced could be. Mm.
Drug induces is remains in the differential of Parkinsonism. Outside of differential
Outside,
of
outside, okay.
Parkinsonism.
It could be from the not I know.
Okay.
Mm, is
How
that
you
what?
would investigate this gentleman?
Yeah. Usually, diagnosis is clinical. However, the investigation to be to rule out other likely causes, in which I'm going to start by doing uh, blood test, routine blood test, and urine 24 hours urine copper estimation to rule out Wilson disease and ceruloplasmin level. And then I will do thyroid function test, do vitamin B assay for other full blood count differentials as for as a routine. Then for the brain MRI to rule out Parkinson plus, and then inspect like that scan to also rule out Parkinson disease, and also for to confirm my diagnosis to it tends to place I think yes, these are the tests I want to do. Then for the visual test I want to do examine the eye using a slit lamp to rule out facial rings in terms of Parkinson. Then
Mm-hmm.
also apart from and then also genetic testing too, maybe get any patient too, if need be.
Okay. What
Mm.
you're looking for in the genetic testing?
I'll be asking for ATP7B gene for Wilson, and then
To rule out
for to rule out Wilson disease, and then for Parkinson, I also check for the PAC gene, and then
any other genetic condition you would like to rule out in this gentleman?
outside Parkinson, outside Wilson, outside uh, essential genetic condition could be yes, Menkes.
I'm sorry?
So what they call is it Menkes is it Menkes disease? I can't remember this. Is it Menkes they call it? One that has 7B. Say Menkes, I think yeah, should Menkes.
No, something more common than this.
Mm, I can't remember any genetic condition that can cause this tremor, aside these ones I've mentioned.
Okay, no problem. Um, how you will manage this case? I'm sorry, I'm taking long in the questions,
It's
milking
okay.
every question possible,
Mm,
okay?
right. Management will involve multidisciplinary approach, which involved both the neurology that is specialized on movement disorders, specialized
Okay.
nurse, physiotherapy, occupational therapy, and also social services that will help in assisting him. Then genetic counselors to be involved too. Then a patient will be counseled about his disease condition. And
Do you,
since
I'm sorry. Do you think, Dr. Henry, that this gentleman does have Wilson because you've mentioned that you would like to rule out Wilson several times? But given his age, do you think that is consistent with suspecting Wilson?
yes, given his age of onset of the condition, Wilson disease is high in the list. Is high in the list. Yeah. So, however, if the liver function test shows elevated liver enzymes, then I have to consider Wilson disease.
If his
If,
liver enzymes is normal.
if the liver enzyme is normal and there's 24 hours, the copper is elevated or the cell or
Normal.
is normal, and then there's absence of Fletcher rings in the eyes.
No kiss of Fletcher rings.
Then there's absence of and there's no wind beating tremor, and there's no evidence the gene doesn't show ATP gene. Then
Have you asked the patient about the nature of his new worsening, Dr. Henry?
no, I did not.
When you asked about the tremor, was
Yeah,
it improving or worsening? You didn't specify. Okay.
yeah, I
So
did not. I did not.
there is a new worsening. Okay.
Okay.
What can explain this new worsening in this gentleman's age? Especially if he tells you that his mom is adopted.
It could be Parkinson's Chorea, but however, Parkinson's
Okay.
Chorea.
This
Yeah,
is what I wanted to hear from you. It needs to be ruled out.
yeah.
It is the only logical explanation, and this is why I stressed out on the screening of function at the beginning of phrasing your examination. Once you started to screen the function, Dr. Henry, you need to complete the screen of function. Otherwise, you missed the important thing that this gentleman does have true acetosis. When he outstretches his hand, you need to ask him to spread out his fingers and you will notice the wraithing.
Mm, mm.
Do you know,
Okay.
are you aware of the screening of function items?
Yeah.
Okay. So now let's put off the questions aside and start analyzing what you have done and how you can improve that. Is that okay? I'm
All
not,
right.
the questions that I've been asked in that way, to be honest.
Okay.
Okay? Do you think that it is 25 years old? 25 years ago, he did have Parkinsonism. Okay, I will go with the story and then tell what I've told. Okay?
All right. Okay.
Once you examine the patient, do the Parkinson's examination. The Parkinson's examination, even though if you didn't remember, if you did the screen of function, you would have noted the movement, the wraithing movement in his hand, because it's
Mm.
outstretch your hand. There is a tremors. Okay, you need to spread out the finger while his eye open. If his finger started to dance, this is true acetosis. What is the pseudoacetosis?
I think in pseudoatotosis, typically you have to once you do that, they don't have,
It will appear
it will appear.
in
Yeah.
whilst the
Mm.
eyes is closed, implicating of or indicative of.
It means pseudoatotosis.
Yeah, so this is the true acetosis we've talked about. Outstretch your
Mm.
hand, spread your fingers. If the fingers should stay normal without dancing, okay?
Okay.
It shouldn't do you recognize, have you seen the acetosis movement of the fingers
Yeah.
before?
Yeah. 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 I have.
Okay. So the fingers will start to spread apart, go low and go up, go low and go up as if it is dancing very slowly. Okay, you need to pay close attention onto that.
Okay.
The true acetosis happens whilst the patient eyes open. Okay? The pseudoacetosis, you ask him to keep his hand the same, close your eyes. He will close his eyes. Okay?
Mm.
And the pseudoacetosis would happen whilst the eye is closed. But if the pseudoacetosis is there, what does this mean?
Means it's not a true acetosis. Most likely it's
Ye-
from.
yeah, what does this mean? What's the problem? The neurological problem.
So I
It's
can't
a
recall.
sensory ataxia.
Means it's sensual ataxia.
Sensory ataxia. So sensory ataxia you can detect it with Romberg and with pseudoacetosis. Okay? The
Okay.
true acetosis is an extrapyramidal symptom. Okay? The true and the pseudo, the difference, eye open, eye closed. As the Romberg, treat it as the Romberg. True Romberg, positive Romberg is if the patient eyes closed, he would lose the awareness. He maintains the balance because of he's aware. He's dependent on his vision to monitor his surrounding. Once this has been cut off, there is no feedback to the cerebellum about the surrounding because of his peripheral neuropathy or sensory involvement, sensory problem. It is the same with the hand. His hand is outstretched. His finger is spread, and once his eyes closed, he start to exhibit this movement that resembles the chorioacetotic movement, but it's not true chorioacetotic movement. This is why they call it pseudoacetosis.
Okay.
Okay. And
All right.
I in the exam, I didn't stratify or distinguish between the two onsets of chorea, of tremors. But I did, the only thing that was spared my head was the screening of function. He had this dancing movement with his hand whilst his eyes open. So I used this to cover my back.
Yeah.
Okay. And then what's the rest of the screening of function?
Following that, we need to text for the.
So ask him to close his hand and suddenly release it strongly. Okay. And then to do the test for bradykinesia with the finger and synkinesis. This is the complete screening of function.
Okay.
Okay? You have to do this in sequence in the very beginning of examining a patient with suspected extrapyramidal symptom, whether it is Parkinson's or its brothers, and the the movement of the limb, any kind of movement. You do this sequence of examination. The patient is sitting, inspect the tremors or the shakiness or the abnormal movement, and then do the screening of function, and then do the gait, do the propulsion test, ask him to lie down or sit back, test the tone for bradykinesia to rule out bradykinesia, test the power. You've missed to test the coordination of the hand, which is very important. Do you know why?
Yeah. In terms of if it's also for Parkinson plus two,
Yeah, which one?
mm, it could be what do you call it, MSA, multiple
MSA
system.
what?
Yeah, MSAC cerebella.
Yes. Okay. Good. Good. So, and then you will test the eyes, okay, for the PSP, and then test the patient communication. There is three communication that's affected. Yes, you've asked for the handwriting, which is good. You are listening to the patient's speech. You can ask him, have you noted any change in your speech recently? Okay. Has your
Okay.
voice tone is always been like that? And expect that the patient in front of you doesn't know what speech mean. So you can use, has your voice has changed. Don't use the word speech. Okay.
Okay. Okay.
Anyone told you that your voice has changed? Okay. And then you are looking to the patient face to negative the hypomania. So we communicate by voice, by handwriting, and by non-verbal cues, which is using facial expression. Okay. And then what you've missed in your history, you didn't clarify the falls. Have you clarified the falls?
No, 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 I didn't. I didn't talk about
You've
if
asked
it's
about the head
falling
injury,
backwards. Yeah.
but
Mm.
you didn't ask, you've asked me in general, have you lost consciousness? I told you I had a falls. Waiting you to say what, how did the fall happens? Have you lost consciousness? What before, during, and after? What he was doing? I was standing and I was sitting. It was multiple. Okay, and what happened during them? I can't remember. I found myself on the floor. Okay, because this is important to be reflected in your management
True.
and in your investigation. Okay. What else? So the examination. Uh, if you find time to do full motor and sensory, they will ask you, sensory is normal because no need to break the patient. Okay, you can
Okay.
just simply ask him, do you uh do you have any pins and needles, any decreased sensation, any injuries? No, and he's not diabetic, so your head is there's you there is no diabetic headache because if there is any diabetes, you will verbalize a lot of question.
Mm.
Uh, so let's mark the skills. I would give you for the physical examination, not because you are bad. No, it's to keep you not to false back you. I will give unsatisfactory. Okay?
All right.
Because you didn't do the screening of function. Just to remind yourself about the screening of
Okay.
function, not to
Mm.
not to
Mm.
say that
Mm. Yeah.
you
Yeah.
did bad. No.
Okay. Yeah.
Um, identifying physical signs. Um, I will give borderline. For the
Okay.
clinical communication, it is borderline.
Okay.
For the differential, your differential. For Parkinsonism, yes. And for what else you've added in your list? You've said Parkinsonism. You've said Wilson. Was that the third differential, Dr. Henry?
Essential tremor.
Essential tremor was your first,
Yeah. And then I mentioned
and then Parkinsonism.
yeah. Then Wilson's disease. Yeah. At the end, you try to Huntington
Yeah.
disease came into play, but at the very end, later end.
So didn't consider Korea. Uh, yeah, just 1 second. Differential diagnosis. Didn't consider Huntington. Korea. Your clinical judgment was borderline. You've managed the patient concerns. You've signposted him to the neurologist. So basically, you didn't affect the patient welfare, so it was maintained. I don't know if Dr. Bassem would be agreeing with me on this or not.
In all skills, and
Yeah.
they call it linked skills. Linked skills. Since he couldn't pick up the finding, he didn't do the physical examination properly. He didn't give the good differential, and he didn't judge or do good management related to the same condition. All of them are linked together. Again, it's called linked skills. Means all the skills related to the diagnosis. If he couldn't pick up the diagnosis, the all skills will be impaired. As in this scenario, he didn't have good diagnosis or proper diagnosis. That's why all skills must be minus. I agree about this judgment. That's why I wrote in the chat box, if everyone can see, the first and the magic question for this scenario, the nature of the movement. What is the nature of this movement? From the start, Dr. Henry. The same as for the weakness. Whenever you have a complaint of weakness, so you will ask him what type of weakness you have. Or the best way, if you want to make to short the time, you can ask him or the examiner, can I see the patient, or can I have a look to the patient, or show me this movement, please, or show me this weakness, or show me this rash. All of them just to give you a clue what type of complaint and analysis I should go through. Because you might go through the Parkinson and tremors, and the case will be Chorea. If you have look or you have a look at your patient from the start, you could pick up this is a Chorea movement or this is a Parkinson and tremors algorithm and approach. That's why you are lost. You don't know. You didn't ask about what the nature of this movement. He told you everything in my body are shaking. but he didn't ask about the nature of this movement. Is it dancing like, or just tremors,
Mm.
shakiness, right?
Yeah.
I think this is the main question you have to ask earlier. So the take-home message for this movement or for abnormal movement approach is to know the nature of this movement from the start. Can I see? Show me, or what is the nature? And you have to know, as Dr. Muammar mentioned, what was and what is it now? What was the nature of this movement and what is it now? It might be a tremor before and now it is Korea, or the opposite, it was Korea and now it's. So you didn't know or you didn't distinguish between the first and the newly appeared. Is it the same? Is it Parkinson and worse in Parkinson? Or Korea and worse in Korea? Or Korea, then now Parkinson? You didn't catch the case from the start. That's why you are lost. You don't know what's the case. Until now, I think still the case not clear for Dr. Henry. I think so, right, Dr. Henry?
Yeah. Actually, the it wasn't that clear because when I entered, he said patient was nodding, shaking his head, and then his hands. So
Yeah, ask him how.
I just felt rest assured that most likely this patient is having perturbation and tremor. So so that was my I think it was like you said, it wasn't really clear in my mind
Yeah, yeah, I
until
think
when we
so.
start.
To
Yeah,
be
we
honest,
said
it wasn't,
yeah,
Henry, it
yeah,
wasn't clear for me when I entered. The patient was keep putting his hand under his feet to control the shakiness. But his
Mm,
body was shaking, his head was
yeah,
shaking, okay?
okay,
And
yeah,
sometimes he put his hand up when he's sitting, and then he put both of his hand under his thighs when he
mm,
was sitting to prevent them from moving.
yeah,
exactly.
So the only thing that I thought it could be if does his hand um, uh, is going away from his body like
mm,
suddenly, is it hemipalism? I didn't know. So
yeah,
when during my examination, the only thing that gave me a clue or a hint was the screening of function, because the patient wasn't that worse. I give the essential tremors as a second diagnosis, and third diagnosis was Korea. Okay, the justification of that, they asked me, do you think that the patient, for the 25 years, did he have Parkinson's by 50 years old? I said, no, it is too early
mm,
for Parkinsonism to be considered in an absence of secondary causes. So, but on screening of function, I have noted that the patient, when I asked him to spread out his finger, there was an acetosis noted. Therefore,
mm,
I am thinking there is an element of chorea,
mm,
and the patient mother is adopted. So this, we don't know if there is any family history or not.
mm,
So I would like to refer the patient for genetic testing. Although I've responded to the patient when he asked me, Doctor, did I have Parkinsonism or Parkinson's? I said, possibly. At this moment, at this very moment, am not very sure. It's usually a clinical diagnosis. We can
mm.
start you on some medication to see if it is improving. Doctor, can I have MRI scan? I said I would discuss your case with the nerve doctors to to give a second opinion on that. If they felt that you need the scan, there is a possibility for you to have a scan. And then he said, "Is does it improve?" I said, "If it is Parkinson's, then with medication, yes, you can get control, and even though there is some other interventions to control the symptoms." And then time's up. One golden advice that I was given in this center, and I think that everyone should know this. Whenever you hear 2 minutes remaining, ask the patient about the concern. Straight away, stop what you are doing, interrupt your flow. Well, given that time is short, can I ask what's your concern? he will start to give you a concern. Don't lose the concern points because they are an easy 4 points. Even though with uncertainty, you can still give a safe answer to the patient concern without improvising diagnosis if it's unclear to you. And this is an easy 4 marks.
Mm, mm.
They will not look, unless you've given a very unsafe answer, mark they will mark you down in the patient concern.
Okay, and what in the feedback? What was the diagnosis? Clear diagnosis in the title.
The no, there's the too long consultation case came, and I
For
would like to
differential.
ask Dr. It was for differential, so
Yeah.
there was no clear sign whatsoever. I did well in this. The feedback hasn't feedback yet, but my score in this station wasn't bad, so it was relatively high, alhamdulillah. So, but the the main thing that's the main theme in this diet that all even though any other candidates I know that have given the exam, all of the long consultation are very vague.
Yeah, yeah.
Mm.
I noticed this recent diet. They are giving a complaint, not a diagnosis. Even the judgment on the complaint analysis, not for the diagnosis itself. So
And
whenever you have good differential, they will give you good mark.
where you will be giving your exam, Dr. Henry?
Dr. Henry in UK, I think. Which center you in UK, Dr. Henry?
Actually, I'm on waiting list, so
Waiting
no
list for
date.
this diet.
Yes, for this diet, yes.
Okay, but
Mm.
there was two in my center. There was two. There was one candidate that was didn't show up. I don't know why. Oh, have withdrawn. I don't know. But anyway, if they're giving you Chester, okay,
Yeah.
it's close or Liverpool, expect the two long consultation to be neuro because it's near
Oh,
to Walton Center and it's one of the biggest neurology centers. They have abundance of neuro cases.
okay.
Okay.
Okay, so it is, and your short neuro station would be an easy, but the long consultation it will be it will be kind of with a neuro theme. You know what I mean?
Yeah.
Okay. Thank you, Dr. Omar, for giving the case to Dr. Henry.
Thank you,
I
Dr. Amma. Thank you.
I think you have now some clues how to approach any abnormal movement in
Yeah.
paces. Yeah. As I said, you can start with the nature and not only the nature. If you're still in doubt, you have to know where exactly this movement start from. Is it originated from the proximal part or from the distal part?
Mm.
Is it unilateral or bilateral? And of course, you have to know the Parkinson itself. As idiopathic, it will appear like what the main nature and what the main movement of the idiopathic Parkinson, Dr. Henry.
Yeah.
What is it? How it looks?
Idiopathic Parkinson usually
Yeah,
is unilateral in terms of the tremor.
perfect.
Yeah.
And what is the nature of this tremor? What we call it?
This tremor is according to what he described, is more like a choretic movement.
Pill
It's not really
rolling,
tremor.
pill rolling, pill rolling.
Okay, in Parkinson is pill rolling, yeah.
Is
Yes,
In
it
yes,
static
Parkinson.
or
this.
Yeah.
kinetic tremor?
Mm,
Yeah, and simply we can say it's pill rolling tremors, right?
Bell rolling
yeah,
static tremors.
Okay.
yeah.
I'm sorry. Yeah, static at rest. Which
Yeah,
static
Mm,
at rest.
resting
Yeah.
tremor. Yeah, resting tremor,
Mm.
which is bell rolling. Okay. So there is multiple question you can ask, or there are multiple question you can ask to know what type of abnormal movement you have. And after distinguishing between either it is tremor, you will go through the tremor and Parkinson or Parkinson plus syndrome, or it is chorea, and I have to know what the underlying cause of this chorea in this patient. So in the either this way or that way. By the way, if you have gone through one of the wrong direction, you will be distracted, you will lose the case. Okay?
Mm.
One of the question also you can add static or dynamic, or is it intention
Kinetic.
or kinetic?
Yeah.
Okay, is it while movement or while moving or while resting? All
Okay.
of them can help you to reach to the diagnosis. Okay, so let's start but for the tremors as a Parkinson. We have reached this is a movement which is resting one, and it's mostly pill rolling. Now I will approach, or I will analyze, or I will try to get what the case I have. Is it idiopathic? Is it Parkinson plus? And I have to write down what are the Parkinson plus I'm looking for. It's not just asking questions. Okay, what are the
Yeah.
Parkinson plus? Dr. Henry.
Yes. Yeah. We have progressive supranuclear gaze
Perfect.
palsy.
PSP, progressive
PSP. Yeah.
supranuclear palsy. What the question
Mm.
for it?
Yeah. As of vertical gaze palsy, typically, they have problem with gaze.
And it will appear when?
It will appear only when they try to look down. So to
Exactly.
look up. Yeah.
So whenever
Look
you
down.
are, yeah, going down the stairs,
Yeah.
you have
Yeah.
any difficulty while going down the stairs, or you have any difficulty while reading.
So how to ask this in the false question? Do you have falls at the in the beginning of the stairs from above or to the end of the stair?
Mm.
This is to differentiate between there is two types of vertical gaze palsy. Either he can't look down, which is the case in Parkinson's plus, so he will have falls in the beginning of the stair, or he can't look up, so he will be having falls at the very down beginning of the stair. Okay?
Mm.
Who can't look up and who can't look down, if you do remember?
For the Parkinson plus.
Yes, but you need to remind yourself with the when you are saying there is vertical gaze palsy, is it inability to look down or inability to look up?
Yeah. Typically is inability to look up.
No,
In
inability to look down.
to look down. In PSP is he can't look down. Uh, uh, and just give me a second to just to clarify this because the CGD he can't look the other way because I started to mix them up. So just one second. Where is the PSP?
You mean for ptosis? Difficult to look up. Ptosis. He cannot raise his
And also the
eyelid.
CGD he will be having CGD
What
will be
what the CGD?
the CJD uh, uh, the
Okay,
Creutzfeldt-Jacobs disease, but it's fine. Anyway. The PSP he can't look
yeah. Don't be
down. Yeah.
distracted away from Parkinson. Now we are talking about Parkinson. So
Mhm.
the first question for Parkinson plus, if the patient cannot look down, so he cannot go down the stairs, or he cannot read the news, for example. So you can ask this question or that. Remember always, it's supranuclear. Supra means up, but the gaze will be down. So the difficulty will be down. However, the term or the name of the disease is supra, directed up. This is the first Parkinson plus. The second Parkinson plus, Dr. Hiner.
Yeah. Is what you call MSA, multi-system
Yeah,
atrophy.
multi-system atrophy. So what you will
Mm.
have in this
So,
scenario?
depending on the subtype, we have those that come with the cerebellar subtype, those that they have.
Okay, cerebellar. So
Mm,
the question for
mm,
cerebellar, you will have
they have the
anastidinous or
yeah,
nystagmus, right?
stagnant here. Yeah.
Or autonomic neuropathy. So the patient
Yes.
might have posterior hypotension, right?
Yeah. Yes.
This is for MSA, multi-system atrophy. What is the
Yeah.
third?
And the third one is it can be vascular dementia.
And what you might have in the
You can
history?
have history of previous stroke or
Perfect.
previous stroke.
Previous stroke or atherosclerosis based on
Sclerosis,
underlying diabetes, underlying
diabetes,
dyslipidemia, underlying
hypertension.
hypertension, or smoking.
Yeah.
So you might have in the history this past history of a medical condition or long-standing condition. And
Yeah.
the fourth one,
Is a corticobasal degeneration.
perfect, corticobasilar degeneration. And how you
Mm.
can ask about it?
They have this alien limb, typically phenomenon, and
Yeah.
many times they have problem with the asterognosis because of their cortical. They have if you
Oh,
have them
okay.
to write something in their hand, maybe write A or maybe 49, they could not identify more of asterognosis. So agraphia. Sometimes they may have alien limb phenomenon.
Okay, so easily or simply, you will draw any shape in on his palm, and the patient will not recognize what it is. So you can do it in the examination, or you can ask him whenever you hold something in your hand, you can know this thing or no. These are the four Parkinson plus. You have to ask about everyone by one question during the history or during doing the examination. Plus, plus you have to have the three triad of Parkinson in the examination, which are what are they?
The three words triad.
The triad of Parkinson.
Yeah, we have bradykinesia, we have tremor,
Perfect.
and we have tremor bradykinesia. We have what do you call it? Trap, tremor, rigidity, akinesia, and
And
posterior
rigidity,
abnormality.
rigidity,
Yeah,
rigidity.
rigidity. Yeah,
Okay,
rigidity.
rigidity,
Mm.
tremors, and bradykinesia.
Bradykinesia. Yeah,
Okay, the rigidity will be in the examination. How you can recognize?
yeah. You
Uh,
may have a cogwheel rigidity.
at
You
what
may have,
level?
at the level of the the joint, all
Which
through as if
joint?
the elbow joint. Can use the elbow joint.
No, no. The
The
elbow
wrist,
will be
the wrist.
another rigidity.
No, when you look at the wrist, hold the wrist, then put your hand on the elbow. Can check for the along the wrist joint. When you one hand should be in the elbow, then one hand should be on the wrist. Then you try to check for the
What's
tone in
the
the wrist.
name? What's the name of the rigidity that is on the
That's
at the level of the
clasp
wrist?
knife, clasp knife, and cogwheel. They have
Yeah.
clasp knife and
So
Okay.
cogwheel rigidity.
Where's
simply, Dr.
cogwheel?
Henry. Yeah.
Pardon?
Uh,
Where is the cogwheel?
at
Cogwheel
what level the cogwheel?
at the wrist.
At the wrist
Yes.
cogwheel. Yes,
Yeah,
this is
yeah,
yeah. So
mm,
the at the level of the wrist, I will have cogwheel, and at the
yeah.
level of the elbow, what I will have?
Clasp
Lead
knife.
pipe or clasp knife. Lead pipe. They like the
Okay,
lead pipe. Okay,
okay,
Because
This is the term.
clasp knife is a different presentation of the lead. But lead pipe, the rigidity will be throughout the movement. Clasp
Yes,
knife, it will be a release
at
and
the
rigidity, release
exactly.
and rigidity, release and rigidity.
Yeah, so it's lead pipe, not clasp knife. Okay.
okay.
And I'm sorry, Dr. Bassam, they if pay attention, don't say clasp knife if there is not, because some angry one, he will say he will mark you down for faking a
For the
sign.
yeah.
Okay.
Okay, let's go back again to the rigidity. Will be cogwheel around the wrist joint, and you have to examine it, and lead pipe around the elbow joint, and you have also to examine it. How you can get it from the tone, examination of the tone. So we are examining always tone, power, reflex, coordination, sensation. Then you can add some of the specific tests for Parkinson, right? What are
Mm.
they, Dr. Henry?
Test for Parkinson. You mean
Specific
test?
tests. Yeah,
Yeah,
specific tests for Parkinson. What are they?
okay. Yeah, typically it's clinical. Parkinson is clinical. However, that the test that you can do
Dr. Henry,
a
I'm asking
that
about
scan.
examination. Dr. Henry, please listen to me. What are the examination steps you have to do?
Okay, step. Okay, I thought you said test.
No, test, I mean examination step.
Okay, examination step. Okay, for Parkinson. We start with the tremor.
We are done with tremor. We are
Okay, the
done with
next
the
thing is
rigidity.
bradykinesia.
Okay, bradykinesia, how to do it?
Yeah, you ask him to open and close his hands as fast
Perfect.
as he can. Yeah,
As fast as you can,
and
please
yeah,
open and copy my movement. And you can
yeah,
open and the index and the thumb movement,
yeah.
inflection and extension
W-
wise. Okay.
One thing you have to add with bradykinesia if it's not evident.
Yeah, you do some maneuver. You ask him to distraction maneuver
No, this is for the tremor.
This is
for
for
the
synkinesia.
yeah. You ask it for the you can ask him to tap his
Yes.
hand on the left on the lap of the other one. Why continue to do on the thigh? He should tap his hand
Yeah.
on the thigh. Why use the other hands to continue to do the open and close. Just
Yeah. So
to reinforce.
this is the third test or examination you have to do, the synkinesia.
Okay.
So you ask the patient with the hand without tremor. Okay. You have tremor, for example, in the right hand. So you'll ask him by using his left hand, tapping his on his thigh,
Somewhere
and yeah, you will notice the tremors will be what will happen
visible.
augmented. Okay. The tremors on the right will be augmented. Means increased. This is what we call it synkinesia.
Oh, okay. Synchronism. Oh,
Okay, so you have bradykinesia, you have synkinesia, and initially we mentioned the rigidity, tremors. One more test or two tests for Parkinson you can have.
then
Examination, I mean, not test. Examination step.
okay, examination. Okay, then you
You
can you
mention it
can
in this case.
yeah we can do the glabella test. We can also do the
No, no,
postural.
no. Don't do the postural one. It's
Okay, we
against
can
the welfare.
yeah we ask him to write his
Yeah,
draw his picture.
exactly. Micrographia. So ask please to write his name. And what about his face? Whenever you examine his face, what you will
Yeah,
find?
they have a mask like face.
Yeah, mask-like face or
Mm.
expressionless face.
Yeah, then the voice to hypomimia.
So so you will state it as hypomania. Don't describe body or symptom that could be offending the patient. Like there is
Mask face.
mask face or expressionless face. It's few tips that they gave in the neuro course, the one in Liverpool. Have you taken it?
No, I did one in London.
Yeah, if you do have
Mm.
the the money, please go for the neuro paces. Please.
In Liverpool.
Yes, please.
Oh,
Okay.
okay.
There is
Back.
one in May.
Yeah. Okay. By the way, you might not have the time to do any course if you are in the late waiting list. They might call you 2 weeks before the exam. This is what I realized in UK. They can call you maybe even 1 week prior to the exam, right? To
Yeah.
attend the exam if you are on the waiting list, isn't?
Yes.
Yeah.
Yeah. Okay. So you don't have the time to go in May course. Okay. Back to our examination steps. If you are suspecting Parkinson plus, what we are missing to do? Now we are done with the Parkinson itself, Parkinson or idiopathic Parkinson. For the Parkinson plus, along with the history, what steps I can add to my examination?
Then I want to check for do ophthalmoplegia eye test to examine
Perfect.
the eye. Yeah.
So the H shape, only H shape. Okay, ophthalmoplegia H shape and mainly downward gaze, right?
Yeah.
So I will do the H shape mainly to the down and I will ask the patient, what about the H shape apart from the supranuclear palsy? Still in the H
Nystagmus.
shape, what I can find?
Nystagmus. Nystagmus.
Perfect. So nystagmus 4
That can serve for the also it can give us evidence of the MSA, multi-system atrophy. It can also
for
give us
cerebellar, yeah, for cerebellar. So
cerebellar.
multi-system for yeah.
Mm.
Okay. And what else for
Also want
Parkinson
to do
plus?
plus the blood pressure while sitting and standing.
Perfect. I will
Yes.
ask for a posture hypertension. Can I check please blood pressure sitting and standing? And the last one, and we mentioned it earlier.
Then we want to do for the upper and lower limb the to see if in terms of vascular dementia, they are more pronounced in the lower limb than upper limb.
So
Mm.
this is for the history. I cannot find it in the examination. Or
Okay.
you can have glucometer check marks, or the blood pressure will be high. But I mean something else. another examination step. We mentioned it a while ago.
Um, okay, we'll talk about the voice, we'll talk about the cerebellar, talk
You
about the
mentioned it, astrognosis, right? So you
astral,
will
yeah, astrognosis, yeah.
so to
Mm.
rule out corticobasilar degeneration. Now I have the all features of Parkinson plus. The last thing to end up with the examination step will be to confirm this is Parkinson. Don't forget it.
To confirm, for, is it still examination, right?
Yeah, yeah, it's one of the examination steps. It's mandatory one. And again, to end up with it, the last thing to do it. Don't start with it.
Mm, is it to write, terms of to
No,
draw?
no, no. You mentioned already micrography. By the way, if you ask the patient to do this examination, you might not have the time to do the other steps. Why? Because he's very slow in doing these steps. What
Okay,
we
the
call it?
gate,
Yeah, the
shuffling
gate.
gate,
Yeah, the
yeah,
shuffling gate. Perfect.
with this hamstring and envelope tone.
Perfect. So now you have the all approach about the Parkinson plus. By the way, you can also add to your approach regarding Parkinson and Parkinson plus the yeah pronator drifts to rule out
Mm.
vascular cause. Okay,
Okay,
pronator drifts. That's it. If you want to do also by Beniski, but I don't think the time will be enough to do all these things.
No, if you asked to examine the lower limb, likely the examiners would say lower limb is normal.
Yeah,
Yeah, I've offered it. They said it's normal, but
offer it.
yeah, no, I asked the patient to sit down. I verbalized that I would I won't. They asked me what you need to why you want the patient to lie on the bed. So they wanted me to continue the examination while the patient is sitting. I said I would like to examine the lower limb. They said it's normal. Continue.
Yeah,
Well, it's I'm sorry, Dr. Bassem. One
yeah,
thing to add for the differential. So you've mentioned, Dr. Henry, that scan
yeah,
is usually to look for Parkinsonism or
hmm,
Parkinson's. Where's the lesion?
yeah.
yeah, the lesion is that the subthalamic nucleus,
No,
the
in
is the
Parkinsonism. In Parkinson's.
apparently is that the negostriator pathway, which is the
Okay,
yeah
okay,
yeah.
good. And
Mm.
in PSP, what you will do? What and MSA? What's
Yeah,
the scan and
yeah.
what's
In,
the lesion?
in PSP, you will do MRI, and then you see what they call the Mickey Mouse appearance because of
No, it's
the
hummingbird appearance.
oh, sorry, hummingbird
Hummingbird.
appearance. Yeah. Then
Due
for
to
the pardon, due to the midbrain,
atrophy of the midbrain. Okay,
midbrain, yeah,
great.
midbrain trophy.
And in MSA,
MSA, you see a cross-bond sign,
hot cross bond sign.
cross
Good, good,
cross-bond sign. Yeah,
good. Due to
yeah. Due to the what do you call this thing again? I can't remember
no
the
problem. But
yeah.
the other thing is that the
Mm.
cerebellum would be also shrunken.
Yes,
So,
yes.
but
Mm.
anyway,
Mm.
if you just mention MRI, if the examiner is asking you what you are looking for, and sometimes, especially this diet, more than one examiner has asked me what you are looking for in the MRI or in the investigation. So you need to
Mm.
have your answer ready. Oh, I
Okay.
want to rule out any hummingbird sign, hot cross bun sign. So
Or
MSA.
vascular cause.
Yeah, but they in since you are mentioning the investigation, if you verbalize that scan and MRI, they will ask what you're looking for in that scan. So any basal ganglia involvement, particularly in in the substantia nigra or the nigrostriatal pathway.
Hmm.
The MRI is will be for PSP and MSA. What's the name of the shape of the lesion or the shape that would appear in the MRI? Hummingbird sign. Does anyone know what's hummingbird? What does
Yes,
hummingbird
yeah,
means?
it's a bird. It's a bird that usually
That can
stands.
remain
Yeah,
static in the air.
yeah.
That type of bird that
Mm,
can remain static in the air, and he does have long beak. It's very famous on the if anyone seen any documentary about the wildlife, they call it the hummingbird. In Arabic, it's الطنان.
It's also called
Um,
Mickey Mouse too. The other you can call it either Mickey Mouse or hummingbird sign. Either sign is
yeah,
it. You can call it Mickey Mouse sign. You can call it hummingbird sign. They are all signs that are keeping with PSP.
and
Either Mickey Mouse or
hot cross bun. If no
mm,
one is might not be aware of that, it's type of sorry, Emeka, I'll just tell it in Arabic. So it's a form of uh, like a bun that they use, and it does have cross on it. Okay, it's a form of bun they eat in Europe, but it does have cross in it from the oven. The when it's baked, it splits, making a shape of cross on the top of the bun. So they call it hot
Actually,
cross bun.
yeah, sorry, Dr. Omar. Actually, the appearance of an image or something can help to
They ask it
diagnose.
here. They
Yeah, I
ask it
know,
here.
but it's really beyond the PACE's scope. Maybe in UK they are too much detailed in the question, but I don't think the time will be enough to reach how the lesion will appear in MRI or I really I didn't hear about it. Even the neurologists they are very difficult to mention it. Anyway, we just added and thank you for adding this information. Let's go back to the history. Sorry, Dr. Amar.
No,
One
no worries.
important part in the history, and Dr. Henry did it really. You have to look for, which is the drug history or
Yes.
any medication list you are taking. Why? What do you
yeah,
think?
because
Yeah,
some medication can be a
perfect.
cause of a cause, yeah.
What they call it, Dr. Henry? What's the name of this
MPTP,
medication? Hmm?
MPTP, MPTP.
Yeah, they call it the group. It's if you said it like that, neuroleptics. Neuroleptics is either
Mm-hmm.
typical antipsychotics or
Antipsychotic, yes.
metoclopramide and domperidone. So both are neuroleptics, which
Neuroleptics,
paralyze
yes.
the dopaminergic neurons. This is the name
Mm.
of neuroleptic.
Yeah, that's why also the management will be adding levodopa or carbidopa. So they augment the dopamine in the receptor on the in the brain as a neurotransmitter. Back to this question, so please don't forget. Even you can put it in one of your differential drug-induced, either tremors, chorea, abnormal movement, and you can add it blindly. But you have to have some medication in the list. Don't say it, and the patient doesn't take any medication. You cannot say it. But you can mention it. I know some drugs can cause it. However, the patient doesn't take it in this way. But if you have one of those medication and you don't know the mechanism of action, you can just say, I would like think about medication, sir. Maybe some of his medication can cause this. Might be taking anti-emetic, for example. Might take as Dr. Omar said, antipsychotic. So think about these things to put it in the differential, even high to the list in the pure differential.
Okay.
Yeah.
And both are blocking the dopaminergic transmission in the dopaminergic pathway, which is
Hmm.
the nigrostriatal. The nigrostriatal pathway is predominantly using the dopamine as a neurotransmitter in it.
Hmm.
So the typical antipsychotics and metoclopramide and domperidone
Yeah.
are does have D2 receptor inhibition, which if it's inhibited, then they they call it neuroleptic because of this mechanism of action.
Yes. And the management again will be dopamine
Stop the
agonists.
medication. Yeah,
Stop the
stop the
medication
medication.
and add dopamine agonists. But if idiopathic, no need to stop the medication. You have to add the medication, which is dopaminic or levodopa, carbidopa,
Yes.
which is dopamine agonist. Okay. Yeah, we are done with the Parkinson plus differential, the
But we didn't talk
tremors.
about the Korea, which is
Yeah,
which
I will
is
leave it.
which is
Let's
important.
yeah. Let's do it maybe on Tuesday if you are free.
Inshallah, I will. But this is the
The
This is
case
the
itself.
case
Okay.
itself for
Okay,
today.
let's.
So
Okay,
yes.
I will just end with the Parkinson or the tremor, not Parkinson.
Mhm.
Adding to our tremor differential, not Parkinson. Of course, whenever you have Parkinson, you have to put the old Parkinson plus as a differential. Exceptionally, you might put another cause of differential for tremors if you don't have a clear Parkinson features. What are the differential of tremors and may be fitting to our case today? As a tremor, again, it's not Korea like, it's tremor,
Mhm.
but it's not Parkinson or Parkinson plus. So let's talk about tremor itself as bilateral tremors. What could be the differential of bilateral tremors in paces or shakiness? In the top of them, Dr. Henry.
Essential tremor.
Perfect. And I have to have
Usually family history.
perfect family history. And
Yeah.
clinically, what I will have in the patient.
It's usually intention tremor.
Intention tremors,
Mm.
head nodding,
Head
right?
nodding, yeah.
And
Perturbation.
it get
And sometimes the who that maybe
and it
pulsating.
and it get worse with
And doing activity, doing anxiety and doing stress.
and
And
it
then
get better with
at rest.
not only with there is something,
There will alcohol too sometimes.
yeah, so
Mm.
yeah, it
Then
improve
beta blockers.
alcohol.
Mm.
Exactly, so it get better with alcohol.
Mm.
There is family history, and it will happen whenever I have outstretched hand, and it will disappear while sleeping. So you can do it in the history by analyzing, taking family history, the nature of the movement itself, both hands, mainly in the hands, bilateral, as I said, and be careful about the driving and sharp object holding. If this patient, for example, is working as carpenter, you should stop him. Okay,
Okay.
he cannot, or he is carrying hot things. He cannot continue working with this disease. Clear? This is the first differential as essential tremor. What is the next differential?
Could be due to maybe could be flapping. We have many kind of tremor. I don't know. Should I go for it in terms of the possibility here? Like if it's not, it could be from the cerebellum, the cerebellar lesion, that may be causing the tremor.
Okay, the tremor in cerebellar, we mentioned it.
Yeah.
You can say what? What type of tremor in cerebellar syndrome?
Cerebellar, you see more like a yeah, could be
Intention,
posterior
intention,
tremor, intention
Intentional.
tremor too. Yeah.
intention tremor.
Mm.
So whenever he's moving, he will have this movement,
Tremor.
or he
Mm.
will have the tremors.
Yeah.
And you can do the finding or the examination of cerebellar syndrome in the form of nystagmus or sorry, finger nose test and the anesthetist. Okay, but I want another differential, which is the third. You
We
can
have
have it in
yeah,
young female.
young female
Yeah.
that would, like in fine tremor. Could be fine
Okay.
tremor from thyroid
Fine
disease,
tremor.
from
Yeah.
thyroid
What?
toxicosis. It could be flapping tremor from end organ disease
Okay.
like
You can mention all organs together: organ failure, liver,
organ failure.
or kidney, or
Mm.
respiratory. All of
Yes,
them can cause flapping
tremor,
tremor.
flapping tremor.
Flapping
Yeah.
tremor, right?
Yes,
Okay. What other? Yeah. This is not I meant. There is another differential I want
yeah.
you to mention.
It could be from Wilson disease. Can cause
No. Okay. Wilson can appear as Parkinson, or it can appear
okay.
as Chorea, so it can fit both differential.
Mm.
But the
Yeah.
patient will be young,
Yeah.
Young
young.
male.
Young with
Mm.
liver disease manifestation.
Yeah.
Okay. Still, you didn't mention what I want you to mention.
Okay. In terms of it could be Korea. So syndrome
No. Don't go to the
for
Korea
tremor.
now,
Okay, tremor,
please. Yeah,
tremor.
tremors. Yeah,
Okay, could be due to um.
please. It's very common, and you have to rule it out. You have to do a specific examination in the body. It's important on one of his organs. It happened with anxiety, sweating.
Okay. Right.
Yes, some doctors start to write it. Yes, both of them are differential. Mention in the chat box.
Leukomotatoma.
right
The
now.
the metabolic causes of tremors.
Yeah,
What are they?
Thyroiditis.
The metabolic causes of tremor.
Yeah, it could be from
endocrine cause.
endocrine causes. Yeah,
Yeah,
hyperthyroidism from.
yeah,
This was the last question they asked me, but the bell rang, so I left. I didn't
yeah.
answer this question.
Uh, that was
It's
how I
very,
mentioned fine tremor.
it's
You
very
could rate as fine
important.
tremor.
Yeah,
They
it's
ask
very.
it this way: are you aware of any metabolic causes of tremors? But the bell rang, so I went out of the room. So I
Wow.
think this is the answer. It's the thyrotoxicosis.
Okay, clear now. Thyrotoxicosis, fuchromocytoma.
Yeah.
Thyrotoxicosis,
Okay.
you might have goiter, or you don't need to have it necessarily as a essential in the finding. Maybe a patient without goiter. Anyway, what I want to say, other finding of tremors or of sorry, thyrotoxicosis, either goiter, or you can say also I might have intolerance to weather, and of course to the hot weather, and sweating. The same as pheochromocytoma, I will find also sweating, anxiety disorder, hypertension. Okay. Now we are done with the tremors as Parkinson or a tremor differential as essential or other cause of tremors, fine tremors. Of course, you can add some medication can cause tremor. On the top of them, Dr. Henry,
Cause of tremor.
yeah,
Medication.
medication can cause tremor.
Yes, medication can cause tremor. Um,
Not as
medication
Parkinson, yeah, as a tremors.
as a tremor. Yeah, beta agonist.
Perfect. What else?
Salbutamol.
Yeah,
Um,
and it happened with
also
asthmatic patients. They might have
yes.
it.
Mm,
Okay, one more. And this is the
um,
last thing to discuss about tremor and Parkinson. But now we are talking about tremor. What is the most
yeah,
common? Yes.
tacrolimus.
Okay,
Uh,
tacrolimus.
yeah,
So
okay.
immunosuppressant in general.
And there is
Yeah,
something not
immunosuppressant.
immunosuppressant and
Mhm.
can cause tremor. And they have two types
Li-
of toxicity. If it's
lithium.
perfect, yes, perfect. Lithium as acute or a chronic. Acute can cause fine and chronic can cause coarse. Okay,
Well,
I think
I think it's the opposite. Chronic can cause fine, and acute the very high levels of it will
no, no,
cause
no,
cores.
no, the opposite.
Opposite.
I'm pretty sure. C for C, chronic for course. You
Okay,
can
okay.
search about it. C for
No,
C, acute for fine.
no, no,
You
no, yeah.
check it, check
Uh,
it. I
I'll
cannot
check
check.
it. Let me just.
Okay, doctor. Maybe I'm wrong, doctor. Okay,
No,
check
no.
it, please. Acute can cause course. Maybe
Yeah,
I'm
this
wrong.
is why. No,
It's
I
okay.
think
Check,
that if
check.
it's very high level, he would be having coarse tremor, making him evolving into seizures. So this is how I remember it. But let me just
Okay,
open my
check again, yes,
notes.
and share it with us. And this is the last point to mention regarding tremors, Parkinson. Now we'll go to the Korea. Korea, how to describe it? So you will ask the patient. Yeah, okay, I'm right. Alhamdulillah. Thank you. Let's go to the next point. Thank you,
Yeah.
real me. I don't know the name. It's okay. The Korea. The nature of the Korea movement will be totally different. So it's dancing like a purposeless movement, and it's coarse, proximal one. Okay, start from the shoulder outward. Easily, you can just ask him to describe. Either he will tell you like this, or you can tell him, please show me this movement. You will find the patient literally he cannot control his body, not his only arm, his whole body. He will do purposeless movement without control. Okay. Now you can ask about how it starts, the onset, course, duration, and so on. But we will talk now about the differential of chorea. What are the possible cause of chorea in cases commonly? We are talking about usually the common cause of complaint. So what are the most common
For
cause?
Korean. It could be physiological or pathological. Okay, common cause it should be due to Huntington's chorea, which is the commonest, which
What is
is
it?
common for patients. Yeah, Huntington's chorea. Then we also can be due to St. Vicious dance, which is syndrome chorea, that is seen in uh,
Post-traumatic, you mean?
no,
Post-traumatic, right?
syndrome chorea.
Sydenham.
No, that is seen in rheumatic fever.
Pregnancy?
Rheumatic fever.
Rheumatic. Yeah, post-traumatic. I
Yeah,
said
rheumatic.
rheumatic.
Yeah,
Okay,
yeah,
post-traumatic. Okay,
post-rheumatic fever.
post-traumatic
Yeah, then
heart disease. So it's called Sydenham.
yeah,
Okay, it's
syndrome
one of the causes, but it's not the common
commonest. Then
uh, high yield one.
yeah, pregnancy, rheumatoid arthritis.
Pregnancy as a physiological cause of chorea.
Yes.
Physiological
Can
cause.
I, yeah, for the cause of Korea, can we divide it? Could it
Okay,
be easier
let's
if it's
yeah,
acute
yeah,
or chronic?
we will recap Doctor
Mm.
with you, Dr. Amar. Let Dr.
Mm.
Henry do his best to
Okay.
reach the
Oh,
all
I'm sorry.
cause. Then
Yeah,
you
yeah,
can
yeah,
no,
yeah,
no,
yeah.
no, it's
Yeah.
okay because he has his own exam. I want him to squeeze himself and to give us the all common cause of Korea. So you mentioned physiological, the pregnancy. The second you mentioned it was Sydenham post-traumatic. What else,
Yes.
Doctor?
Huntington's chorea.
Sorry?
Huntington's disease, HD.
Huntington. This is what I
Mm,
want you to mention.
mm.
It's not a common disease, or I mean, as prevalence, but it's common in patients. They want you to mention it if you have suspicion, in particular, if you have family history. So Huntington, Korea. What else?
Systemic lupus erythematosus,
Perfect.
Yes.
SL.
Yeah, vasculitis,
Mm,
post-vasculitis. What
yeah.
else?
Then I think also
Metabolic.
metabolic.
Perfect. Yes,
Yeah.
Wilson.
Wilson.
As I said earlier, Wilson can appear with a tremor as a Parkinson, or it can appear as chorea. Okay, this is the I think this is fifth. What else as a chorea cause?
Uh, so rheumatoid arthritis. Not too
Connective
sure.
tissue.
I'm not too sure, but uh,
Okay, I don't think
No,
it can
no, it
cause.
doesn't. It doesn't cause Korea.
Yeah, yeah, it doesn't cause. What else? We mentioned it earlier. You can put it as a joker with any manifestation. You can put this differential,
thyroid.
No, no,
not
no.
as
No. It is from the pattern. It will be recognized from the pattern that comes and goes.
Comes and goes.
Yeah, relapsing, remitting.
Okay, okay, MS.
Hmm.
what is it?
Multiple sclerosis.
Multiple sclerosis? No, no,
No,
it doesn't cause.
you said MS. Okay, I don't know the last one. Sorry.
As I said earlier,
Oh,
if you have some medication, you can say drugs induced.
drug induced.
A drug. Okay, okay.
Okay, I'm done with my differential in paces. Commonly as a case on the top of them, not as a common in the real life. The Huntington, they like whenever you have long course of this chorea or abnormal movement with family history, with the mood change, behavior change, they like to mention Huntington. Okay, Wilson as well. You can put it as a metabolic. If you have again family history, if you have chronic liver disease manifestation, you can put it. Okay, then whatever you mention, it's already there. The vasculitic, as you mentioned, the SLE, or post-traumatic fever, Sydenham, physiological pregnancy, or drug-induced. In this way, you cover most of them. Now we can hear Dr. Omar if he has another.
No,
Okay,
usually an easier approach, like,
okay.
or not easy for, but if Dr. Henry didn't have a prepared one, you can just classify it acute or chronic. If it's something comes, if it's this Korea movement happens acutely, vascular causes needs to be ruled out, such as strokes involving the subcortical region, metabolic causes, okay, although it's very rare, but it needs to be ruled out, which is the hyperglycemic induced chorea or polycythemia rubra vera. Drug induced is one of the acute causes because it's chronic. If it's chronic, SLE, if the patient is migrant, if because Dr. Henry is giving his exam here in UK, so UK can say if the patient is from different ethnicity, we can consider Sydenham chorea, secondary to rheumatic fever, or rare but important is the Huntington.
Okay.
And you stop. It's just 30 seconds. You've said all of the causes.
Okay.
Yeah, perfect. I like one of the chat box message, hemibalismus.
Yeah,
Now I we
the
will.
differential diagnosis.
It's differential, but what the difference, main difference between hemibalismus and Korea, Dr. Henry?
I think hemibalismus is forcefully is one-sided one.
Perfect.
And
Yeah,
yeah.
from
Mm,
the term itself, hemi
mm,
means a side or one side in the body, so
mm.
unilateral. And what is the cause of hemibalismus?
Is the balismus is from the I
The
mentioned it
lesion,
previously.
the
So from the
lesion.
thalamic nucleus,
Yeah,
Yes.
subthalamic,
subthalamus,
subthalamic. Yeah. So
subthalamus nucleus.
hemi for sub, hemi for
Subthalamus.
sub. This is what I can remember always. Hemi, something
Mm.
part or partial. Sub, something also down or behind or below. So it's like in this way you can remember subthalamic for hemipalesmus. Okay. Now I think we are done with the Korea. Of course, according to the cause, you will treat or you will investigate or you will do whatever according to the case itself. The presentation, of course, you have to think about the age presentation. Is it young or elderly? Is it male or female? Okay, so it will look different and the approach will be different.
If it's Huntington, how you will manage Dr. Emeka?
If
Okay,
it's
this is
Huntington's,
the last
management
part
we
of our session today, Dr. Henry.
okay. If it's
Answer Dr. Ahmed.
Huntington's,
Yeah.
management we MDT, including the genetic counselors, the neurologists that specialize in movement disorders, physiotherapists, occupational therapy, and then social services if needed. In this case, as part of the drug, there are some drug known as I think tetrabenazine, which has been shown to help in the choretic movement, and then also improve the quality of life. Then also part of counseling on these on likely because of the events of anticipation to counsel them of for the possibility of giving birth to future
Hmm.
condition, future individual with a certain condition. I think basically outside this MDT is just place them on tetrabenazine and then
Hmm.
treat symptomatically and then
Okay. Would you advocate for genetic testing?
Perfect. Good.
um
The same
yes,
question I would like to ask.
yes. I would in this case for genetic counseling, if it is voluntarily, if the patient comes that wants to test as a voluntarily, usually we don't test for children that are not of age, except probably those of them if they are willing to be tested. But because of the it has its own pros and cons anyway. One of the pros is that it helps them make decision early. Then, but the cons in it is that it can make them feel more anxious and sometimes cause unnecessary
Dr.
fear.
Henry, Dr. Henry, yes or no? You will advocate, you encourage for genetic screening.
No,
That's
No.
it.
Okay.
When
no.
Uh,
exactly the
Mm,
exceptional
yeah, this was my.
situation you will do
mm.
the genetic counseling or
Yeah,
screening? When?
It's three situations. Three.
but
But
for
this will come as a communication station.
Exactly. It will
yeah.
be as a
Mm.
communication center. Tell us the three situation you will screen.
Yeah, if the this situation I want to screen for genetic counseling, if the person has come down with disease, just to know the particular gene that is for research purposes and then for medical legal purposes.
Okay.
Mm.
Okay. Can you think of anything else?
Um, so that thing.
Okay. So let's break it. The three things are: first thing, if the patient wants to start family, so he need to have the gene test, so they can have something called pre-implantation genetic diagnosis or selection via intra vivo or extra vivo fertilization IVF. Other option that you should give to the patient is sperm donation, but it does have some cultural and religious challenges. This is the offer for the if he asked you the question, is there any other option? Okay. The second indication will be enrollment in RCT or randomized control trial that is looking for treatment. The third would be, you've said it, the legal or medical legal, or it's better to be said it for financial support claim. If he declared that he will have debilitating disease, then he will have rights for certain or access for certain claims. But at the same time, the the cons will be that life insurance, travel insurance will be higher.
Yes, exactly. But the most important to mention is the family for planning to start a family. This is the most important one. Others are like minor indication, but the major indication to have safe baby by doing the genetic selection or a sperm selection or ova selection according to the gender. Otherwise,
Mhm.
yeah,
The reason to put the three in mind, because in the communication station, you don't know what is the patient concern. His concern might be, oh, is there any other option other than extra fertilization? You should have one ready in mind, which is the sperm donation. Okay. Enrollment. He might be inquiring, is there any test or treatment? I'm sure there is any. So you can have something ready in your mind. I will look and see if there is any ongoing trial in or I would refer you for the neurology team that can consider the enrollment and trial. So you can have something to play with. Did you get my point, Dr.
Yeah,
Bassem?
yeah, yeah.
yeah. Again, it will be in the communication in that much detail.
Mhm.
Anyway, for the main, as I said, the most important one, the family planned or plan to have a family. Okay, thank you, Dr. Omar. Any question regarding the Korea or tremor or Parkinson? I'm done with the session today. Anyone want to add any comment or question?
Yes, good night, Dr. Basim, or good morning.
Good, Dr. Mahmoud.
How are you, Dr. Omar? How are
Congratulations,
you?
Mr.
I'm
Mahmoud.
fine.
Thank you,
Congratulations.
So
Dr.
we
Basim.
have two of our
Yeah.
success doctors or candidate, Dr. Omar and Dr. Mahmoud.
Thank you, Dr.
Really,
Basim.
it's
Thank you very
many
much.
congratulations. You deserve it, both of you.
Thank you, Dr.
Thank,
Bassem.
just
Hard worker, yes. I
thanks,
wish.
Dr. Basim. Really, this long journey,
Yeah, a long journey, yes. This is what I want to say.
1 year.
Never ever give up. This
Yes,
is Dr. Mahmoud after a long time, maybe 1 year, yes. Multiple attempt, yes. It's something not really. It's not something shameful. Instead, it's something to be brave. That still I am doing my hard work. I want to pass this exam. I will never ever give up. This is what Dr. Mahmoud did. He
Mm.
didn't give up. Even in the same center, he think it could be still difficult, but he did it. In the same center, he failed the first time.
yes. ده
Yeah,
قصر عيني.
yes, exactly. So finally, he did it. Alhamdulillah. That's why we are so happy for him. Of course, along with Dr. Omar, both of you, and if any doctor also attend with this the last week resulted, we will say to them, congratulations. We are so happy for all of you. Yes, Dr. Mahmoud. Sorry, I
Yes,
interrupted you. Yes, you can
no, no,
talk
Dr.
now.
Basim. Just I wanted to aid the examination of the Korea. Because there is a specific examination to the Korea. There is two signs of Korea, milky meat sign and Jack in the
Perfect.
box.
We
Yes,
didn't talk
the
about
most
that.
important.
Yes, you're right.
This is the first thing. And second thing is that as Dr. Omar mentioned, acute chorea and chronic chorea. Acute chorea will be three causes and must be mentioned to the examiner. Three causes is first vascular and infection and metabolic like hyperglycemia. And we have to mention the three things to the examiner because infection will worsen the blood sugar, and also blood sugar will cause infection. That is the second thing. Just I finished, but I wanted to mention one thing, Dr. Basim, from the last diet, from my last exam. Don't say like that only simple thing I will not mention to the examiner. I will give an example. In my neuro station, the patient was sensory level sensation, sensory loss. Okay. I examined the patient neurologically in the lower limb. I can't see that the patient had hyperreflexia, so I don't do the clonus. But the patient already have a clonus, have clonus. Okay, and the tone I think it is normal, and sensation was lost up to the umbilicus. So when I tell the examiner this patient has sensory loss level, and the examiner tell me, okay, what else? So I didn't find in the patient anything. So I said I see there is a urinary bag besides the patient. I tell the examiner, and there is urinary bag, urinary cluster in the patient. Um, all my colleague in the same carousel doesn't mention the urinary bag, and they lost identify physical signs in this station because they didn't mention urinary bag. I give this in this station full mark, but the examiner give all my colleague in the same carousel just eight, because of in the feedback he write urinary bag not mentioned.
Oh my God. Imagine,
Yes,
imagine to observe something very stupid.
yes,
Obvious. Yeah.
Yeah,
it is.
it's stupid. It's not exam wise, but they like the way to think that I find something maybe not important, but it's important. It's not
Yes,
important as a general examination and or neurological examination, but it's important in indirect way. Maybe the patient is having incontinence or not. He doesn't have the incontinence, maybe for another reason. But I meant
yes.
I mention it. So this is very important. Not only the urine bag. Sorry for interruption, Dr. Mahmoud.
Yes, okay, doctor.
Wallahi, I can swear. Even cannula. If you have a cannula and you mention it, it gives a good impression to the examiner. Or, as Dr. Mahmoud said, if you don't mention it, he might mark you down.
Yes, although Dr. Basim, all my colleague said that there is a clonus and there is hyperreflexia, and I didn't mention the clonus, and I didn't do
Yes,
clonus.
yes,
I give the full mark because of the urinary bag. Just
yes.
that.
I believe
Uh,
that.
yes, yes. My friend in the same carousel sent me the feedback. Just the examiner, right? Candidate did not mention the urinary cluster. Although,
Imagine.
yes, Dr. Basim, I have the feedback now.
Okay.
Although we see all of us see the back, and all of us do the gate, but just I mentioned the urinary bag by I think by luck, because I
Yes,
can't
yes.
find in the patient anything like anything other than urinary bag and sensory level, spinal cord level.
It's something from Allah.
Yes, I think
He
it's something
wished
from Allah.
that to say it and to get the mark and to pass the exam. Maybe this mark might fail the whole exam, by the way. Maybe one mark in one skill, either to fail you or to pass you. Okay.
Yes, just
And yeah, I want to add also something very important, maybe also related to the case, and maybe the doctors will not notice it. And I know one of the doctors, he noticed this thing while explaining the management plan, not in the finding. Okay, he didn't say anything about it in the finding, but he mentioned it during the management plan. He asked the candidate what other management plan you could do. He mentioned a multidisciplinary, and when he reached the occupational therapist, he looked around the patient. Occupational therapist means things to help the patient to cope with the life. And during mentioning this, he remember there is a wheelchair beside the patient, and he mentioned, I can notice wheelchair patient need, and it helped him also to gain the mark.
Mhm.
So it's important, the surrounding more maybe important than the finding on the patient himself. Yes,
Yes,
it's not.
another
Yes.
example, Dr. Basim, sorry, another
Yeah.
example in the same exam. The cardiology station, the patient has in his hand systemic sclerosis. Anyone not mentioned the hand has systemic sclerosis lose the mark also
Yes.
Yes, I
in the
agree.
cardiology station.
I agree. Yeah, yes, it's
So not give up, and also
exactly.
I have
In my neurology station, Dr. Mahmoud, sorry for interruption, the patient just had one scar, two scars in the feet. And the other candidate was talking about uh, Charcot-Marie tooth.
Mhm.
But I've mentioned the scar, and I said it's likely due to
Peripheral neuropathy.
no, Charcot joint.
Okay. Yes.
This was the only thing that, but because the other candidate, when we was discussing the cases as it happens in any exam, they said it's Charcot-Marie tooth, Charcot-Marie tooth, Charcot-Marie tooth. So I went, my heart was racing. Did I miss the Charcot-Marie tooth? But then no, it wasn't, because the patient was able to cock his ankles back toward him very strongly, and he pressed my hand against the bed. So he doesn't have ankle drop. So I agree. Very small things can. It's not by your own
Yes.
detective eye. It's
Yeah.
by not by luck, but
Yeah.
uh, by guidance from Allah Subhanahu wa Taala. But it's
Yes.
these very small things just
Yes.
uh,
You're
to
right,
pay
Dr. Amar.
attention for.
Yes. To impress the examiner. The last comment I will mention, then we will end this session. Uh, Whenever you have diabetic patient, imagine the importance of mentioning the trophic change in the legs, shiny skin, loss of hair, some ulcers, pigmentation are very important identifying finding, which is not related to the complaint, for example, but means that there is a complication and the patient having long-standing diabetes, which is not well controlled. Full stop. Thank you, Dr. Omar, Dr. Henry. Special thank Dr. Omar. He was volunteered to give the case to Dr. Henry today without having another case because he really passed the exam. Thank you, Dr. Omar, also, Dr. Mahmoud,
Thank
sorry.
you. Thank you so much.
Thank you, Dr. Henry. Any question before ending the session? So we can say thanks everyone for the attendance today. See you tomorrow, inshallah, the communication day.
Inshallah.
Good luck and good night. Assalamu alaikum wa rahmatullahi wa
Assalamu
barakatuh.
alaikum.
عليكم السلام ورحمة الله وبركاته.
Assalamu alaikum.